Thank you, and it's great to be here. I was at a conference a few weeks ago. It was a conference of state legislators from different states, and we had a very interesting speaker that talked about Obamacare and the implementation in the states and all of these really important decisions that are going to have to be made by state legislators. And at the end of the presentation, the floor was opened up for discussion, and so many of the legislators just kind of had this blank look on their faces, like, oh man, and there was really no discussion after that. And then the next discussion, the next policy discussion for that breakout session was about local bag ordinance policy, where you're looking at whether your local Vons or Safeway needs to charge you for the use of a plastic bag, or you need to use a reusable bag, or whatever. And the discussion that opened up afterwards was like an hour long, and I was thinking, wow, like healthcare is a really important policy area, and bag ordinance policy is important as well. But the dollars associated with healthcare are just astounding, and it just made me laugh. Like, wow. There just wasn't much discussion, and I don't think it's an issue of legislators not being engaged on healthcare or not wanting or not caring, but I think it's an issue of the enormity of the decisions that have to be made, the costs that are associated with various programs that are going to be implemented, and kind of the fact that healthcare has been rife with political conflict for so long. But the fact is that this is a really important issue, and Medicaid is a huge portion of state budgets all across the country, and the issues are not going to go away, and we've got to get very smart about how we're spending our Medicaid dollars. So I wanted to talk a little bit about Medicaid cost containment. Just a little background on Molina Healthcare. We are a multi-state Medicaid managed care organization. We've got sort of three business sectors. We run health plans, and we contract with state Medicaid agencies to manage the Medicaid managed care programs. We also contract with some states for the Medicaid management information systems, so we're paying the claims for the fee-for-service systems. And then we also have a variety of clinics sprinkled across the country where we actually employ primary care doctors that see patients. So we've kind of gotten in all three sectors. And this is just a little business snapshot so you can see where our business is. We're sprinkled around the country. We've got about 1.8 million members nationwide. And so we've got experience in a lot of red states, a lot of blue states, and everywhere in between. It's interesting to work in the various political cultures. And so I'm not going to go through all of these Medicaid cost containment ideas because I don't have time, but I wanted to just throw some ideas out there and touch briefly on a few of them. One of the first one I wanted to talk about was issues related to non-emergent use of emergency rooms. This is an issue that is close to our hearts at Molina Healthcare because our founder was an emergency room physician who was seeing a lot of people come through the ER that didn't need to be seen in an ER setting, and they had colds and runny noses and sore throats. So he opened up a few clinics in the Long Beach, California area and started seeing patients in those settings. So we're focused on this issue, and we see this as not a, the issues that I've outlined here, or the ideas I've outlined here, are not individually going to change the world in Medicaid spending, but together, taken, these ideas can make an impact. So, non-emergency use of the ER, or non-emergent use of the ER, can be looked at in a couple of different ways. You can create a co-payment for the member that's coming into the emergency room for a non-emergent condition, and as my colleague to my right mentioned, there are a lot of CMS strings attached to it, and we've worked in a couple of our states to try to get these off the ground. In California, for example, the state wanted to implement a $50 co-payment for non-emergent use of the ER, but that proposal had to be scaled back a little bit. It's now hovering around $15, and the medical directors of the health plans are working with the Medicaid agency in developing a program that makes sense for consumers and also makes sense for the state. Right now, they're looking at creating a list of diagnosis codes that would necessarily be non-emergent, and whether or not there would be a copay attached to those would require a health plan to look through the claims and do an analysis. What we're finding right now is that claims analysis is going to cost more than $15, so maybe it's not the best way to do it. In the commercial plan world, you know, many of us have health insurance, and we know that there might be a copay attached to the emergency room visit, but if we're admitted, it gets waived. If we're not admitted, we pay for it. And creating a program like that would be much simpler to administer and might actually help change some behavior on the member side and save a little bit of money. And then there's also the second way to look at changing behavior with non-emergent use of the ER, and that's changing the way that hospitals or emergency rooms are reimbursed. And there's one thing you can do is create some sort of lower level fee paid to reimbursed to the hospital for the services that they're providing to triage people, because you want the hospital is spending some time to making sure that the person that comes in the door doesn't really have an emergent condition and they need to triage them. And we respect that when we need hospitals to be paid for those services. So to create a smaller payment for that medical screening exam or that triage process would be a smart way. That way the hospital does not have the incentive to make it a full-on emergency visit and spend a lot more resources on that patient than is actually necessary. So that's one important issue that we've been trying to work on with our states. Another way to incentivize health plans that contract with state Medicaid agencies to run the Medicaid programs is to create an auto assignment mechanism that encourages health plans to be the lower cost plan to the state or be the higher quality plan. And this is something that California has been, at least on the quality side, has been using for quite some time. And there's a committee that meets every year to determine which quality metrics are going to be used in the coming year to determine in a certain geography where you have competing plans, if Plan A scores highest on the HEDIS metrics that are designed for that year, they're going to get a little bit higher number of auto assignments for those folks that don't actually select the health plan that are auto-enrolled. And California is trying to create a low-cost plan factor in that auto assignment mechanism. We're working on it with them. It's something that we think will help health plans be a little bit more competitive in their pricing, which can positively impact the Medicaid budgets. Also, we've got the out-of-network payment limitations. I won't go into too much detail about that. And then care coordination opportunities, the dual eligible integration programs that a lot of states are working on right now. There really is potentially good financial savings in those, and also opportunities for making quality for patients a lot better. And then we've seen in a lot of our markets a lot of managed care expansions into new geographies and new populations, and carving in certain benefits that have traditionally been excluded from managed care. There are also some pharmacy utilization ideas. Again, I won't spend any time going through all these. One important issue that I wanted to touch on today, which is not so much a Medicaid cost containment idea, but it's something that states need to be thinking about in 2013 and 2014, and that is the Affordable Care Act's health insurer fee. This is a fee that is on the entire managed care industry, and There are some carve-outs for certain Medicaid lines of business, but not all Medicaid lines of business. So come 2014, there are going to be Medicaid managed care plans that are responsible for paying this fee or this tax. And as you know, the rates that managed care plans get paid by the state Medicaid agencies need to be actuarially sound and have to include administrative costs and the fees and taxes that are due to the state and federal governments. So even though this is a federal tax on health plans, for those health plans that are participating in Medicaid, that the state is going to have to fund at least their portion of that tax. And that is going to be a cost on states that really hasn't been discussed very often. So this is an important issue for state legislators to be thinking about as they're building budgets for the coming years. And the NGA has come out with a letter of concern about this issue to the Obama administration. And various health plans are talking about it, and some Medicaid directors have gotten a little bit involved, but it just hasn't really changed anything yet, or it hasn't changed yet. And so it's an issue that we're watching closely. And then the final thing I wanted to touch on was not so much a Medicaid program concept, but something Molina Healthcare did in a few of our markets. And the idea came out mostly as a way to deal with the problem of missed appointments, that we had a lot of our members were missing appointments to our clinics, and a lot of our members have serious transportation challenges, and we want to be able to get our patients into their doctor's offices, to the pharmacies to pick up their prescriptions, to the grocery stores to be able to pick up their healthy foods, and to their community centers so they can access important social things that they need. And so we created neighborhood shuttles in some of our markets. And this is an example of our Long Beach, California route. It's a 14-mile route, and it hits a bunch of different grocery stores and community centers, a couple churches, and then our medical center is on the route also. The shuttle is open to anybody that wants to ride it. It doesn't need to be a Molina member. And we have found that it has increased our members' ability to get to appointments, and it's increased our members' ability to pick up prescriptions, and there's a little bit more prescription compliance, with medical compliance to those treatments. So that's something that is unique to Molina, but it's an idea for state Medicaid agencies to just, as a reminder, to look to your managed care plan partners, because there are a lot of innovative ideas that they want to create, and they, if done right, they can really make an impact on the overall budget for their plan, and then also the budget for Medicaid. So that's my contact information if anyone has any questions, and I'm happy to answer any questions later. Thank you.